Good afternoon. I'm Katrina Metcalf. I'm one of the nurse practitioners at Heart and Vascular at Valley View, and welcome to the Valley View University. This is part of our women's series. We're going to focus on heart health for women today. I do work in the cardiology office at Valley View, so I want to thank everyone for joining us because women are very important and our hearts are, they lead the way. I have a few housekeeping items to get kind of out of the way before we get started. One is that at the bottom of the screen, there's a question and answer portion. You feel free to type in your question there. My only request is that you don't leave any personal information, date of birth, age, previous diagnoses. Those, because of HIPAA laws, we can't address those questions. So if you put those in the questions, we have to put those aside. So if you leave any personal information, just know that we're not going to be able to get to your question. But generalized questions, especially about medications or follow-up or referrals, things like that, please feel free to ask. We'll try our best to answer everyone's questions. If we don't get to everyone's questions, we can always follow up via email if we need to. Okay, let's get started. So as I said before, my name is Katrina Metcalf. I'm a nurse practitioner. I've worked in cardiology for going on 15 years, both as a nurse and a nurse practitioner. I've been with Valley View for a little over 2 years. And I primarily am in the clinic in the Grand Junction office. However, I'm up back and forth between the Glenwood office also. For today, I'm just going to kind of go through our PowerPoint here. Let's see here. There we go. I want to start. So when we think about heart disease, the majority of the focus on heart disease nowadays is what we call vascular heart disease. Vascular heart disease is part of the plumbing system. It's when you have a heart attack, you have vascular heart disease. But vascular disease is not the only type of heart disease women can have. And so why the majority of our focus will be on vascular heart disease, because it is the #1 killer of women in America, I do want to touch bases on some of the other types of heart disease so that patients who have other symptoms are not going to ignore them just because they don't fit one category of heart disease. So when we think about heart disease, there's essentially 3 types of heart disease. We have a structural, an electrical, and a vascular. When I talk to people about heart disease, I always equate the heart to a house. If you think about how a house is built, we have the walls of the house. And so you have the walls that hold everything in place. And then you have the doors between the rooms and the walls. We have the electrical system that runs through the walls. And then on top of that, we have the plumbing system that also runs through those walls. When you think of your heart, it's like the house. If your wall is crumbling, then the electrical system or the plumbing system also is going to be affected by that change. So even though one may start with one type of heart disease, it can frequently spill over into other types of heart disease. And so you may have multiple different tests for multiple different types of heart disease. And that's okay, because we need to figure out if it's the walls or the plumbing or the electrical that's causing the concern. Structural heart disease. So structural heart disease are those walls in the doors. It's a condition that involves the heart valves. And so the valves are these flaps that sit between the chambers. Your heart has 4 chambers, and valves sit between the chambers of the heart to let blood flow forward and not backwards. People can have types of structural heart disease. They can be congenital. They can happen later on in life. They can be a primary structural heart disease, say that one of your valves changes or for lack of a better term, goes bad over time. Or you can have a weakening in the wall of the heart from lack of blood flow or from high, fast heart rates. So that's where structural heart disease and the other 2, electrical and plumbing, can all kind of play into each other. Infection is also a way that heart muscle or the structure of your heart can be changed. Women have very specific heart disease that we're more tend to have. Structural heart disease, when you think about people who have heart failure, that's a failure of the muscle of the heart to properly squeeze the blood out and about to the rest of the body. That type of heart disease can affect men and women, but women are prone to different types of changes in that muscle. Weakening of the heart muscle, a very fancy term for that is called a cardiomyopathy. And women tend to have more secondary caused cardiomyopathies, one of which in particularly women are prone to is called broken heart syndrome. It's an actual disease. It's called a stress-induced cardiomyopathy. And 90% of women who are diagnosed with that type of weakening of the heart muscle are women. And so the concern with that is that broken heart syndrome is usually secondary to a large event where stress hormones actually impact how well that heart can squeeze and relax. It's usually reversible, but it very much mimics the symptoms of a heart attack. People become acutely short of breath. They can have types of chest pain or pressure. They can feel very faint and fatigued. And so that type of broken heart syndrome is very much women oriented. The other type of structural heart disease that can happen more frequently in women is called mitral valve disease. The mitral valve is one of those doors that sit between the top and the bottom chambers of the heart, and it keeps blood from going backwards. It keeps blood to go forward to the next chamber of the heart. And women are thought to be more prone to mitral disease secondary to our hormone levels. Mitral valve disease can be very genetic also. If your mother had mitral valve disease, you are more likely to have that run in your family in a maternal or female genetics. One of the things that is a larger concern and is becoming more prevalent in the United States in particular is pregnancy-related cardiomyopathies. Women are waiting longer to have children. And so the age above 35 with your first pregnancy, and if you have a history of high blood pressure, you're more likely to have what we call a pregnancy-related cardiomyopathy, whereas the fluid and the hormones from pregnancy actually weaken that heart muscle and can cause trouble for both mom and the baby. Depending on which study you look at, it's anywhere from 1 in 1,000 to 1 in 4,000 women will have this type of weakening of the heart muscle throughout pregnancy. And so that's something that if you are a later age gestation, just make sure that you have those conversations with your OB and that you're aware of the risk and the symptoms of heart failure during pregnancy. So that's kind of structurally, so the walls of your house or your heart, those are kind of specific to women. Like I said, we're going to focus on kind of the vascular portion towards the end of the presentation, but I do always like to run through the other types of heart disease that women can have. So we've gone through the walls, and now we want to go through the electrical system that runs through those walls of the muscle, and it's what tells that heart to squeeze and relax, usually in a nice normal rhythm. Our heart beats from the top, lub, and then the signal goes to the bottom, dub. And so when you listen to your heart, that's where we get that lubbed up, lubbed up. The electrical system, it's a fiber of the system. Electrical fibers run through the muscle of the heart, and they can become irregular. They can be out of sync with each other, where the top part of your heart and your bottom part of your heart doesn't beat together. So you don't get the lub dub, you just get the dub. And it can go fast, or it can go slow, or it can skip beats, which can happen frequency. Common electrical diagnoses, especially in women in particular, which we'll go through, are atrial fibrillation. It's a very common term. We hear it a lot of commercials on TV talk about medications regarding atrial fibrillation, but atrial fibrillation is where that top part of your heart, instead of squeezing well together, it kind of vibrates or fibrillates, and it doesn't move blood very efficiently through the heart. The other type of common electrical diagnosis are things like PVCs, which is a premature contraction that can come from the bottom or the top part of the heart. And it's when you listen to a heart and it skips a beat every once in a while, or people feel that they have a flop in their chest, they can have that extra beat that comes in early into the cycle and can cause some symptoms. Women's specific arrhythmias are atrial fibrillation, which we talked about before. Atrial fibrillation affects men and women. However, the older women get, above 8, or especially above 75, the more likely to have a new diagnosis of atrial fibrillation be women. The risk of death and stroke associated with atrial fibrillation is higher in women than men because we tend to not seek treatment early. And if we do seek treatment, sometimes our symptoms are categorized as something else, such as anxiety or palpitations or being out of shape, when in truly those palpitations are actually atrial fibrillation. So we have a higher risk of stroke and death with the atrial fibrillation than our male counterparts. However, when we do have atrial fibrillation as women, we do tend to have more symptoms. We're more, for lack of a better term, in tune to our bodies. And so if something is wrong, we know that. Atrial fibrillation can be frustrating for women in particular because it can cause a lot of anxiety. There is a head-heart connection. We know that. That's been studied over the years. And so when something is wrong with our heart, such as fibrillation or fast heart rates, it can make us feel very anxious. And unfortunately, anxiety sometimes is dismissed instead of investigating the cause of the anxiety. Likewise, for women in the childbearing ages, pregnancy hormones can also, those increase in pregnancy hormones in particular, can cause faster heart rates. So women during pregnancy tend to have a faster heart rate, and they can also go into heart rates above 120, 130, 140s and stay high, and those are called tachycardias. Younger females, especially in their teens and 20s, are more likely to have palpitations or skipped beats around their menstrual cycles because that decrease in estrogen and the increase in progesterone during that natural cycle irritates the electrical system of the heart. So that's the electrical system of the heart. Now we're gonna touch bases on the vascular system. That is the system of blood flow. So vascular refers to any of the blood vessels in your body. There's the high pressure system, the arterial system of your blood vessels. That takes blood away from your heart. It has all the oxygen and nutrients that your cells need. And then the venous system is that low oxygen, low pressure system that brings all of that, I call it used blood, back up into the heart and the system to get recirculated again. Vascular disease, while we're going to focus on the heart and the cardiac structure today, it can happen anywhere in the body. Vascular disease can cause a heart attack. And heart attack is where the blood flow to the heart muscle is stopped, and that muscle is not getting nutrients or oxygen and can be damaged or even die. Blood flow blockage to the brain is a stroke, and it's the same series of events. What happens is oxygen and nutrients doesn't get to the brain, and portions of the brain can die. But it can happen to your legs. The blood flow to your legs can be stopped or limited. The blood flow to your kidneys can be restricted and stopped. And so when we talk about vascular disease, we're going to focus on the cardiac structure. But one thing I always like to tell people is if you have blood flow concerns to the heart muscle, you can also have blood flow concerns to the other portions of your body, kidneys, brain, and legs. And so when we think about heart disease, we often look for other types of disease to catch it before it causes of trouble. Vascular disease in the United States is the #1 killer of women. 1 in 3 deaths in the United States is caused by heart disease. And when we talk about heart disease, that's specifically vascular heart disease. And so it has historically been and will and has continued to be a very concerning aspect of medicine. Um, Women are very individualized when it comes to vascular symptoms and vascular risks. We frequently don't have, and we frequently don't have typical chest pain as men do, you know, the chest pain with elephants sitting on your chest pressure. That is mostly a male symptom. It can happen to females. And when I say this, you know, I never discount any symptoms. If you're having typical symptoms, fantastic, get those looked at. But our focus today is really to help women understand that not everybody is the same, and we can have different symptoms than our male counterparts. Frequently, women have different symptoms. Nausea is a big one when people are having a heart attack or an acute event. Things that can be warning signs for people who are building up to having a heart attack is shortness of breath or fatigue. And once again, that anxiety level in women can increase if there's a concern with your heart, and is often one of the symptoms that gets dismissed the earliest. Patients are often told that, oh, you're just anxious and your symptoms are because of anxiety, when really, truly, there's a physiological reason for that level of anxiety. One of the things that women frequently have also is they say that I just had really bad heartburn that day. I didn't actually have chest pain. I just had this epigastric or high stomach pain. And so heartburn, yes, women do tend to get heartburn, especially postmenopausal because of our lack of estrogen. But I never want people to ignore heartburn symptoms also. When it comes to women and vascular heart disease, unfortunately, even though, and we'll talk about the changes in screening and inclusion in studies in just a little bit, but unfortunately, women continue not to be screened at an early age. And in fact, men are usually screened 5 to 10 years earlier for heart disease than a woman of the same age. And so there's still that bias, unfortunately, in medicine that women don't have heart disease and that we don't screen routinely for that. One of the things that can affect vascular disease in particular is women tend to, because of our body habitus and how we metabolize medications, we tend to be more sensitive to medications. So our side effects may be worse than our male counterparts. And so we have a less likelihood to be compliant with some of the medications that have been prescribed, and that includes cholesterol medications and blood pressure medications. So we're going to go back to and really focus on vascular heart disease and how we prevent that, and how we make sure that we're getting early treatment and frequent treatment with our vascular disease as women. But I do want to talk to you a little bit more about women in particular and our anatomy. Women, of course, are in most cases smaller than men. We have smaller blood vessels. And so with that smaller blood vessels, we tend to have what we call microvascular disease, whereas the small blood vessels tend to have more disease than our larger blood vessels. And that can be frustrating to treat because the smaller the blood vessel that has a blockage in it, the harder it is to correct that blockage. Also, we have a decreased red blood cell count than our male counterparts, and so we have a lower oxygen level carrying capacity than our cohorts, and that can also change how well we oxygenate and circulate our nutrients throughout our body, especially post-menopausal. Menopause is, as I'm sure everyone knows who's gone through it or is going through it, can change your life significantly. Outside of the hormone changes, it also significantly changes how our body uses cholesterol, how our blood vessels can dilate, can become bigger or smaller. And so estrogen is, the lack of estrogen when we hit postmenopausal can really increase the risk for cardiovascular disease. And rescreening, even if you were screened during menopause or before menopause, really, truly, you should be rescreened for vascular heart disease after your menopause. So let's talk a little bit, we know that heart disease is a large concern in our world, especially in the United States. We have a very Western diet, which can be high in processed foods and high fat. But historically, women have been left out of a lot of our research, a lot of our education, a lot of our marketing when it comes to heart disease. And so when we talk about women and for lack of, we need to get the word out. We need to share with our sisters and our aunts and our moms and our grandmas the risk of heart disease. And unfortunately, we're still lacking in our ability to do that. And so when we talk about women and heart disease, especially with the research that, hey, this is a big problem in women, one of the first studies to really highlight that there might have been a difference between men and women actually may be having heart disease, is a study that is still ongoing. It's a longitudinal study. It's multi-generational. It's actually a pretty amazing, it's now a whole organization in itself. It's called the Framingham Heart Study. Started in 1948. And then, so it followed, in particular, families over time, fathers, sons. And in the 1980s, they realized that the daughters of fathers who are having heart disease and high blood pressure and high cholesterol levels were also having the same symptoms as their sons. And so they started reporting specific patterns of heart disease in women in the late 1980s. And their conclusion, right around 1988 or so, was that women actually did have heart disease, and we might want to look a little closer into what type of heart disease they are more prevalent for and how we screen for that in the female population. From that kind of conclusion with the Framingham Heart Study, the National Institute of Health in 1989 changed its policy requesting that women become equitable in research. And so if you're going to have a study involving a heart medication or a specific procedure to correct heart disease, that women were also included in that study, which was extremely rare before then. So up until essentially 1990, women were not part of any research for cardiology. In the 1990s, women really started to gain momentum. The American Heart Association and the American Heart Association and the American College of Cardiologists, both are great organizations. They got together and made this campaign. And the campaign in particularly was more of a marketing and education campaign. And it said, we really need to get the word out that women are dying of heart disease and they're not being screened and they're not letting anyone know that they have symptoms. And so they really pushed this in the late 90s to the early 2000s. And by 2003, we had some improvement. So I don't know, if you were to pool the population, about 13% of women in 2003 said, okay, I'm at risk for heart disease, which is still a very horridly low percentage of women who realize that heart disease is a killer. In 2004, the American Heart Association launched their Go Red for Women. And that's been one of the most successful campaign in the United States to educate women and increase their knowledge of vascular heart disease. I'm sure everyone has seen those little red pins that women in particular, can wear. February is Heart Month, so we always like to wear red for women in February. In fact, tomorrow I think is the day for wear red for women, and so I recommend that everybody tomorrow take their friends, their sisters, their aunts out to coffee or lunch or brunch and talk about heart disease, because while it is still a good marketing campaign, unfortunately we're losing ground on it. And when I say losing ground, the Go Red for Women was launched in 2004. It had a great success for about 5 years. We increased our knowledge in the female population of the United States. When we did a survey in 2003, 13% of the people said, okay, I could be at risk for heart disease. By 2009, we had increased that number up to 65%. That is amazing. Those are great gains, but it didn't last. And so we had all of this this momentum, and it kind of fizzled out. And so the last survey that they did was actually prior to COVID in 2019, and we had lost ground. Only 44% of women in 2019 realized that heart disease was a killer of women. And so when we talk about marketing in particular for heart disease, the best way to do heart disease and market for heart disease in women is with each other. So when we talk about Go Red for Women, one of the things I really want to push today is talk to your family members. Talk to your family members about your family history. Talk to your physician about things that you can do to educate yourself and the people around you about heart disease, because knowledge at the end of the day is what's going to change this trend in heart disease killing women. So we've kind of talked about what our hearts are composed of, the three types of heart disease. We've talked about how women need to be made more aware that heart disease is a killer of women. And so just for a second, we're just going to take a step back, and I just want to talk real quick about treatment of structural and electrical heart disease. And then we're really going to focus on this number one killer of women, this vascular heart disease. And so when we talk about how to treat women with structural heart disease, and that structure, remember, that's the walls, that's the doors, the muscle, the valves. One of the things that I really want people to be aware of is that the symptoms for all three of these types of heart disease can overlap with each other. And so symptoms of structural heart disease are often fatigue, shortness of breath. You may go to your annual visit and your provider says, "Hey, did you know you had a murmur?" And you say, "Oh, I have a murmur. Let's look at that," because we never want to dismiss any kind of changes in a cardiovascular structure without looking at those. Structural heart disease, we talked about that broken heart syndrome, that acute change in how well that heart beats, squeezes, and relaxes. That can cause chest pain, which can mimic vascular disease. And so I never want anyone to dismiss any of their symptoms if you have a concern that it could be coming from your heart. There's diagnostic testing we can do to check for structural heart disease. A lot of those are ultrasounds of the heart, blood work, or simply an EKG where we put all those stickers on your chest and tell you to hold real still for a few seconds. So very non-invasive ways to get good information about your heart. And there's different types of treatment depending on the disease process: medication, surgery, exercise, and diet. You will notice that there will be a theme from here on out when I talk about heart disease, and a lot of that is going to be lifestyle modification, diet, exercise, knowing your numbers. So how do we treat electrical portions of heart disease? And that's that arrhythmias, or that change in the electrical system, or how fast or slow or what rhythm our hearts are in. The symptoms for those a lot of the times are palpitations. Women have more palpitations than men. They're also dismissed much more than men. If a man goes to a doctor and says, "I have palpitations," they get a monitor, they get this whole workup. Women go to their doctor, and I'm generalizing, not all doctors are this way, or not all providers are this way, but if a woman goes to a provider and says, "I'm having palpitations," the first thing they're asked about, "Are you anxious? Are you anxious?" And so yes, anxiety can cause palpitations, but it could be a different causation. And so I never want women in particular to be called anxious when there's a secondary symptom that could be there. So if you're having palpitations, or you're short of breath every time you try to do anything, heaven forbid you're passing out or coming near passing out, which is syncope, we want to make sure that we let our providers know that, so that they can do these non-invasive tests to see what's going on. Same thing with structural heart disease. We have treatment with medication, surgery. Palpitations or changing in that electrical system can be caused by excess caffeine, or supplements that have these weight loss supplements in particular kind of have these stimulants in them that can cause changes in the electrical system. And so when we talk to our providers about palpitations or changes in the electrical system, we really want to make sure that we know everything that you're taking, including, any kind of supplements. And then back to that whole diet, exercise, lifestyle, that also can help with arrhythmias. Okay, so let's get back to really the focus of this talk, which is heart health for women. And when we talk about heart health for women, the one thing that kills women more than anything else in this country, including all types of cancer, breast cancer, ovarian cancer, colon cancer, all of those combined, do not get us to the numbers of heart disease. Heart disease is the number one killer of women. And when we talk about vascular disease, I'm going to focus on the heart because that's what I do. That's my job. That's what I love. But just know that vascular disease is not just the heart. It's also the brain, the kidneys, the legs. Vascular disease can happen anywhere in the body. So when we talk about vascular disease, there are things we can do to prevent vascular disease. And medicine, especially Western medicine, has always historically focused on treatment instead of prevention. When it comes to heart disease, you don't want to get treatment. You want to prevent heart disease from ever occurring. There's two types of causations of heart disease. One are things that we can change. Those are the reversible things. Our blood sugars, our blood pressure, smoking, alcohol, diet, exercise. Do we take our medications? Those are reversible causes that we have control of. And especially as women, that we can change to improve our lives and reverse or even reduce our risk, if not reverse our vascular disease that has occurred. Unfortunately, women also have non-reversible factors when it comes to vascular heart disease. Your genetics. I always say that's the gift that just keeps giving from your parents. If you have a strong family history of early heart attacks or frequent heart attacks, if grandma and grandpa both had, open heart surgery in their 50s and your parents in their 50s had stents and things like that, those are genetics and you need to be aware of those. Those are things that we can't change, but we can be aware of and limit our reversible causes so that our genetics don't play a part. Age. Unfortunately, the more birthdays we have, the higher risk we have for vascular disease. Just like everything else in our bodies, age can be negative in how our processes work. And so we need to be aware that while I was screened in my 30s and 40s for vascular disease, or even in my 50s, I'm in my late 60s or my 70s now, and I need to be rescreened. So age is a big factor in vascular disease. We talked about this previously, menopausal state, premenopausal, you have a lower risk of vascular disease or heart disease. Postmenopausal, because of our lack of estrogen, it actually increases our risk of having a heart attack or stroke. Non-reversible causes, especially here in Colorado, there is still a large population that live in rural areas outside of our ability to seek regular cardiac care. And so our primary care providers are really our lifelines in those communities. And so access to healthcare is sometimes non-reversible, but really, truly, the small town provider is the one person that does very well with screening a lot of the times because they do everything. So access to healthcare can also be a factor in prevention over time. So let's talk about non-reversible causes. Non-reversible causes are things that we just can't change. And so if we know we have a non-reversible cause when it comes to vascular heart disease, we need to make sure that we mitigate that risk with changing our reversible causes. And so I encourage women in particularly, I don't know about you guys, but my family is not big on talking about healthcare, and especially grandma never talked to mom about healthcare. Mom never talks to me about healthcare. And so we want to change that cycle. We want to change a cycle where you're having and asking those difficult questions to grandmothers, great aunts, mothers, sisters. Have you had any cardiac history? How old were you when you had a heart attack? If you have a family member, aunt, uncle, or an aunt or a grandmother or a mom who had what we call early event, which is a heart attack or a stroke before the age of 50, you need to be screened regularly so that you don't have an early event. family history of frequent events. So even though your family member, your mom, is on all of the right medications, she continues to have cardiac events or heart attacks or strokes. You need to be screened, and you need to know that and understand your risk factors and how to mitigate those. We talked about age. The older we are, the more likely we are to have a heart attack. Menopausal state. Estrogen plays a very important role in our bodies. It regulates blood pressure, and it regulates how our bodies use cholesterol. Estrogen also helps reduce inflammation, and it helps our blood vessels expand and contract easily. And there's been a lot of controversy over the years on about hormone replacement therapy. I'll leave that to the hormone replacement people, but from a cardiac standpoint, it doesn't change your risk factors. Even if you're on hormone replacement therapy, postmenopausal decrease in estrogen, whether you're replacing it or not, the changes still occur, and you're still at risk for vascular events. Access to healthcare, especially in our rural areas, we've talked about that. Sometimes there's a cultural barrier. Sometimes there can be a lack of trust. We've been dismissed previously for other things, especially as women. It's anxiety, it's stress, it's because you're a little overweight. And so there can be a lack of trust with our healthcare providers. We'll talk about that a little bit more, but really what we need to do is be our own advocates and not take no for an answer. So those are non-reversible causes that everyone needs to be aware of, but more importantly, really get down into your family history so that you know and your provider knows whether you're at high risk for vascular events. Reversible causes. There is a long list of reversible causes that can affect vascular heart disease in women. First and foremost, because of our change in how our society is from 100, 150 years ago, we're much less active as a society. We eat more processed food and sugar than we ever have in our most recent timeframes as humans. And so we have a large epidemic of type 2 diabetes in our society. Type 2 diabetics, elevated blood sugars, promote what we call soft plaque. So when cholesterol gets laid down in your blood vessel, that cholesterol is very soft, and it's more likely to rupture and cause a heart attack than, say, if you weren't a diabetic. Type 2 diabetics are 5 times more likely to have a heart attack or a stroke than those who do not have type 2 diabetes. And so when we talk about prevention of vascular heart disease later on in this, we're really going to push that even though you've never had an event, if you're a type 2 diabetic, we treat you like you've had a heart attack before because you're at that much more risk to have one in the future. Likewise, we really need to be proactive about treating our type 2 diabetes. If you're diagnosed with type 2 diabetes, please don't ignore it. Make the lifestyle changes, losing the weight, watching our sugars and our carbs. That's going to help lower our blood sugars, which then in turn will lower our plaque deposits and reduce our risk of heart attack or stroke. Blood pressure. Elevated blood pressures can actually stiffen the blood vessel walls that lead to everywhere in the body, the brain, legs, the heart. And so that lack of elasticity in our blood vessels reduces blood flow to the brain and the heart, and over time can cause heart failure. That's that muscle of the heart can change over time. And the vascular system can also be more likely to have tears or ruptures because of those high blood pressures. Blood pressures for most women should be 130/80 or less. Those numbers have changed over time. It used to be 140/90 when you take your blood pressure, and we're now realizing that if we can get even better control, 130/80 with blood pressures or less, and that is with diet, exercise, or medications, that you're less likely to have vascular heart disease with low blood pressures. I don't think I have to kill this this next topic. We all know that smoking's bad for you. Smoking is, I always tell people, if you smoke, it's not when you have a heart attack, it's or not if you have a heart attack, it's when you have a heart attack. Smoking causes inflammation in the blood vessels. It will lay down cholesterol and plaque inside those blood vessels, and you will have blockages to your legs, to your brain, to your heart. It's a horrible habit, and it's horrible to quit smoking, and we all understand that, and we appreciate that. But if there's one thing we can do for our health through all of this, smoking is the one we need to stop. Alcohol. Alcohol, over the last 20 years, there's been multiple different types of recommendations when it comes to alcohol. Have your red wine, don't have your red wine. The current thought on alcohol is low to moderate, and that's up to 1 drink a day for women. And when we talk about a glass of wine for women, it's 4 ounces. It's not 8 ounces. It's the 4-ounce glass of wine a day. That's called moderate if you have 1 drink a day. And it may actually help protect your heart because it increases your HDL, which is your good cholesterol numbers that help reduce inflammation over time. If you're a heavy alcohol drinker, that's more than 2 glasses of alcohol a day. And when we talk about alcohol, it's 1 shot of hard liquor is considered a drink. So 1 ounce or 2 ounces of hard liquor, 1 shot a day, or 1 beer or 1 glass of wine, 4-ounce glass of wine, that is considered 1 drink. Anything more than that a day is considered to be heavy consumption, and that actually increases inflammation, increases blood pressure, and can weaken the heart muscle over time. So if you're going to have your glass of wine, stick to once a day, and try not to do any binge drinking over the weekend. So reversible, one of the things I really want to focus on for vascular heart disease is the reversible cause of heart disease is diet, exercise, and weight. And that's true for heart disease. That's true for osteoarthritis. That's true for type 2 diabetes. If you eat a good diet and you exercise regularly and your weight is at a reasonable level, you're less likely to have all of those disease processes. Particularly for vascular heart disease, we want to follow a low cholesterol. Cholesterol is a type of animal fat. We get it from dairy, we get it from meat. We want to follow a low cholesterol diet. The less cholesterol or fat circulating in our blood to be laid down as plaque reduces the risk of it building over time and having blockages. One of the ways to decrease the amount of cholesterol our body absorbs in our diet is to increase our fiber. Fiber actually holds on to cholesterol and fat in the GI system and can help pull it through instead of having it be absorbed into our system. And then sodium. So sodium is important in heart disease because the higher amount of salt in your diet, the higher your blood pressure is going to be. High salt has you hold on to fluid, causes higher blood pressure, which then increases decreases how well your blood vessels can contract and restrict, and increases how much plaque gets laid down in your blood vessels. Low sodium diet is recommended from a heart standpoint, and it's very hard to do, especially in our Western diets. The highest place, it's very rare that people can have a high sodium diet by just adding salt from the salt shaker. It's actually in the food we eat. The more processed the food, the higher the sodium content, and that's because it's the only way we can get processed food to taste good is to make it very salty. So when we're talking about diet and low sodium, we really need to start reducing our reliance on processed foods. Exercise is a reversible cause for heart disease. Your heart is a muscle. The more you move, the healthier it's going to be. Exercise goal for a cardiac exercise plan is 150 minutes of moderate intensity exercise a week. And when we talk about moderate intensity, that's not you're so out of breath, I can't talk. I just have so I can't talk. That's not moderate intensity. Moderate intensity is going for a walk with your girlfriend and you have to take a deep breath every 3 or 4 words because your heart rates are higher and you're breathing harder. But it's not a full out sprint. It's not, you're swimming and you're beating your time every single day. Moderate exercise is just getting up and moving. And my recommendation, especially for women with exercise, is anything that's weight bearing. If you're going to exercise for your heart, we want that. We want that cardiovascular benefit. But we also want that bone benefit, especially if you're postmenopausal. And if you do weight bearing activities, walking, running, things like that, then it also gives you that help with your bone structure. So you have that weight bearing to help keep your bones strong on top of your heart. If you're not exercising currently or you don't exercise routinely, I do not recommend that you go out and start exercising 150 milligrams or 150 minutes a day. Build up to it. What I always tell people is start with 5 minutes a day. Once you get comfortable with 5 minutes a day, increase to 10 minutes and then increase in 5-minute increments until you get to about 30 minutes a day, 5 times a week. That is a goal for your heart and to keep it healthy and strong long term. With diet and exercise comes weight control. A BMI less than 25 results in reduced risk of both inflammation and cardiometabolic changes, which is a nice way of saying the lower your weight is, the less strain on your heart as it moves throughout the day with basic activities. So I don't know about you, but I really hate going to the doctor and telling them telling me that I'm overweight and that I need to lose weight. But it really, it's important, especially from a vascular and a heart standpoint, to keep your weight at a minimum. And there's a lot of different ways to do that with diet and food and exercise and some medications. I know we had some earlier talk in January about weight loss and things like that. And so those are good things to talk to your primary care about, especially in a cardiovascular sense. So vascular heart disease. So vascular heart disease is when the inside of your blood vessel, so if you have your blood vessel, the inside of that blood vessel is being narrowed by cholesterol, by plaque. Plaque is being laid down on the edge of that blood vessel, and the blood flow downstream is being narrowed over time until it eventually gets so narrow or stops completely that it causes an event, a heart attack or a stroke. And so one of the best ways at the end of the day to reduce your risk of having vascular heart disease is to keep your cholesterol or your lipid panel under control. There's two scales for cholesterol. One is what we call primary prevention. Those are when you go for your annual visit and you don't have a personal history of stroke, you don't have a personal history of having a heart attack, and you're not a type 2 diabetic, and you don't have any family history of early heart disease, then you're in what we call your primary prevention. Primary prevention is keeping our total cholesterol under 200 and our LDL under 100. That reduces our risk that the circulating cholesterol in our blood vessels are going to be laid down at plaque and cause trouble in the future. Secondary prevention are for people, we have tighter control on cholesterol. And the reason for that is we know you've had a heart attack before, so you're likely to lay down plaque and cause problems. You've had a previous stroke. You're a type 2 diabetic, so remember you're 5 times higher to have an acute event, a heart attack or stroke, if you're a type 2 diabetic. So we need to make sure that cholesterol isn't being laid down. And so those numbers are kept at a little tighter frame. And so we want your total cholesterol less than 150 and your LDL less than 70. And when we talk about cholesterol, you get your cholesterol panel back and you have your total cholesterol, you have your LDL, which is the low density lipoproteins. Those are the bad cholesterol. LDL is bad. HDL is good. High density proteins, lipoproteins, those are the ones that actually are beneficial. They reduce inflammation. And we really, truly, from a heart standpoint, we treat the LDL. I understand that people come and say, but my HDL is really great and my triglycerides are low. But at the end of the day, if your LDL is high, you're going to be laying down that plaque. And so that's the number that we treat. We treat your total and we treat your LDL. So I know that there can be frustration with medicine, that every time I go to the doctor, somebody gives me a new pill. And cholesterol in particularly can be treated very easily and very well with medication. However, when patients come to see me in my clinic and they have elevated cholesterol panels, I am always willing to have a conversation about lifestyle modification. Lifestyle modification is treating your body with food and exercise so that it heals itself. And so when we talk to lifestyle modification, we want to treat our health with healthy foods. And so we want to follow these diets that reduce our cholesterol, that reduce our blood pressure. And that's a low cholesterol, low sodium diet, low sugar, low processed foods. If you change the way you eat from a high processed, high fat diet to a whole food, fresh fruit and vegetable, lean meat diet, you can reverse high blood pressure, you can reverse your cholesterol, you can reverse diabetes. The kicker with that is it has to be a long-term change. And that's where we can struggle a little bit as humans. We see a good benefit from a change in a diet, and then we slide back into eating things we know we shouldn't. And so when you're talking to your providers about cholesterol and finding a healthy weight and maintaining blood pressure, the first thing you should have a conversation with is diet. What can I change in my diet? What can I treat my health with so that I don't have to take the medications? And so that's what I recommend everybody starts with, is lifestyle modifications. Change the way you eat. If you know your blood sugars are creeping up and you're becoming near diabetic, if you know your cholesterols are high and you're starting to have to go on blood pressure medication, first and foremost, change your diet. Changing your diet can reverse these disease processes to the point where you may never have to use medication. So that's what I always have a conversation with my patients first. Lifestyle modification, change our diet. Exercise, move every single day. Go for a walk every day. Really try to build up and hit that goal of 150 minutes a week of physical activity. That's going to strengthen your bones. That's going to strengthen your muscles. That's going to strengthen your heart and your vascular systems. And the other thing that, especially with women, we tend to internalize stress. And so stress reduction, yoga, meditation, exercise, anything to reduce stress reduces stress hormones, which then reduce our blood pressure and reduce the way we use blood sugar. And so those three things, when I talk to people before I put people on medications to treat heart disease, I talk to them about diet, exercise, and stress reduction. If we can, over a 6-month period, change those three things, we may never have to go any further than that. And so prevention is truly the key to life. And I encourage people to start that now instead of waiting until they're diagnosed with diabetes or until you have your heart attack. Treat your lifestyle now, and then you don't ever have to worry about any of that. However, if we do get to the point where we've had some sort of event, or we know our cholesterol is high, or we're high risk for cardiovascular disease, we really need to do some lipid management. The best way to manage your lipid or your cholesterol panel is with a statin medication. Lowering your risk of heart attack and stroke by up to 40% can be done by taking a statin medication. Statins do two things. They reduce the amount of that LDL that circulates in your blood to be laid down as plaque. And then the plaque that is already accumulated in your blood is what we call stabilized. So plaque, if you look at down the barrel of an artery, plaque is very bumpy and rough. And what can happen is it can break pieces off like a side of a cliff on a rock. It can break off and kind of fall into the bloodstream, and it can block blood flow downstream. It can catch red blood cells or platelets and cause a clot, which causes an acute stroke or a heart attack. And so that plaque, if it's not treated with a statin or statin-like medication, it's at risk for what we call fracturing and becoming unstable and causing a heart attack or stroke. So when we think about statin medications, not only do we get the benefit of reducing our cholesterol levels, but we also get that plaque stabilization, which can prevent an acute event in the future. There is some concern with certain populations that they're not able to take statin medications. They can cause you to have what we call myalgias or muscle pain and weakness. Depending on the data, it can be anywhere from 10 to 25% of patients who take a statin can have that type of side effect. And so we know that if you can't take a statin, you're back to having that increased risk of having vascular disease. And so there's been some other products that have been brought on to the market that reduce your LDL and stabilize plaque. The other two are injectables, the PCSK9 inhibitors, like Repatha or Praluent are the brand names. Those are injectables. They're subcutaneous. You can do those at home, and you take them once or twice a month, and those reduce your cholesterol levels and stabilize plaque. And there's a newer type of injection, and it's done once or twice a year, and it significantly can reduce your LDLs, and the brand name for that is Leqvio. And you can go into that really when we get to that level of the injectables for cholesterol management. That's usually done through a cardiology office or a lipidologist. And so those are our other options. So people who come to me and say, I have these risks of having vascular disease, or I've had a heart attack and stroke, but I can't take statins, just know that there are other options out there, and you're not just kind of left to just have another stroke or heart attack in the future. There are ways to prevent that. So vascular heart disease, I'm going to say it again. 1 in 3 deaths in the United States is from a heart attack or stroke. Vascular disease kills women, and we need to be more proactive. We need to educate ourselves. We need to educate our family members. We need to educate our friends, and we need to be proactive so that we change that number. We don't want heart disease to kill women. Not in this day and age when we can do so much to prevent it. And so women are different. We need to know, we need to be more proactive in our health, especially when it comes to heart disease. And so when I talk to women in my office, I say, you need to know what your numbers are. You need to know your baseline cholesterol numbers, and you need to have your cholesterol levels and your blood pressures and your blood sugars. You need to have all of that checked routinely. And that can be done through a cardiologist, that can be done through a primary care. But somebody needs to be looking at your numbers. You need to know what your baseline is so that when they start to change, you're on top of that and you don't wait until you have an event. You can prevent an event. Likewise, if you were screened for cholesterol, blood pressure, blood sugar before menopause, and now you're after menopause, rescreen. We know that the lack of estrogen increases that risk, and your numbers will change. Talk to our families. Talk to your aunts, to your grandmas, to your moms. Know your family history of heart disease. Knowing your family history will help your providers prevent you from going down that same line. Women in general, we tend to ignore non-urgent symptoms. And so that's why it's very important for women to have routine healthcare screenings with their provider. Go to your annual visits. Go to your medication follow-ups. We want to talk regularly. We want to screen and rescreen, and we don't want to overlook these kind of broad symptoms that could be just about anything, but really truly are cardiac focused. And one of the things that really truly women get pushed aside for or not recognized as a cardiac symptom is shortness of breath. What I could do 6 months ago, now I'm huffing and puffing, walking down the block or running up those stairs. I used to be able to do it without any problem. Now I have to stop at the top of the stairs and catch my breath. That new shortness of breath or that new activity intolerance, those could be signs of an early blockage in that blood vessels, and we need to look for that. Overwhelming fatigue. Man, I can get all my stuff done, but every time I sit down, I fall asleep. I sit down after dinner and I'm asleep on the couch every night. That overwhelming fatigue is not normal, and it needs to be looked at, whether that's vascular, or some type of other metabolic. We need to look at fatigue. Fatigue is not a normal occurrence for humans. We all get tired every once in a while, especially if, we're out running around and doing a busy day and exercising, but we shouldn't have an overwhelming fatigue. And once again, palpitations are not normal. Racing hearts, skipped beats, those are not normal. Those are not anxiety. Make sure that you really do talk to your primary care or your provider about palpitations. They need to be looked into. Women are different. So we're now past the point of prevention. We good or bad, maybe didn't take care of our blood pressure and our cholesterol, or we didn't know to take care of our blood pressure or cholesterol, or we didn't get rescreened, or something has changed in our life. And now we're at the point where we're having what we call emergent symptoms. When women have heart attacks, lack of blood flow to the heart muscle. We have a clog in the blood vessel that's taking blood flow to that heart muscle, and that muscle is starving for oxygen, nutrients, it's dying. That's a heart attack. Women rarely have chest pain. Please don't ever say to yourself, I don't have chest pain, so I can't be having a heart attack. That is not how women are built. Women have pain between their shoulder blades. Feels like you're kind of being stabbed in the back there. We have shoulder pain, doesn't have to be left-sided, can be right-sided, can be, front of the shoulder, can be back of the shoulder. We have back pain, we have shoulder pain, we have jaw pain. Jaw pain in particularly is the one that people miss. So all of a sudden, this is just horrible. Every time I get to get up and try to do anything, or my heart rate goes up, I get this horrible pain in my jaw. I must have a bad tooth. That is not tooth pain. Tooth pain is something that's there no matter what. When you're resting, when you're activity, this is pain in your jaw that doesn't go away, or that can come and go, and it's just horrible, and it's acutely onset. Jaw pain, shoulder pain, back pain, especially if it's associated with this kind of, oh man, I'm hot, I'm sweaty, I'm nauseous, I just don't feel right. That overwhelming feeling of I don't feel right, you're having a heart attack. Those are the symptoms that you need to go to the emergency room with. Do not say because I'm not having chest pain that I'm not having a heart attack. Women are different. We don't have chest pain. We have back pain. We have shoulder pain. We have jaw pain. We have pain up here in our upper abdomen, like we're having heartburn. That's very common. I just have a really bad case of heartburn that's not going away. That is not heartburn. If you have pain like that, where you're sweaty and you have this sense of dread or anxiety, I want you to go to the emergency room. I do not want you to delay. When it comes to your heart, it is better safe than sorry. Never do we want a woman to sit at home and have a heart attack. Your symptoms will sometimes get better. You say, oh, well, I went to bed and 2 days later, that chest pain in my chest got better. And then a month later, you end up in heart failure because that blood vessel that was blocked killed the muscle of your heart. And so never do I want you to sit at home if you think you're having any of these symptoms that are associated with having a heart attack. I am always under the philosophy, and you can talk to any emergency room physician in the world, better safe than sorry. If you have symptoms that are concerning or having a heart attack or a stroke, then you need to go to the emergency room right away. And so that's another thing when you take your grandmother, your aunt, or your friend, or your sister to lunch, brunch, or coffee tomorrow, I want you to talk about the difference between men and women when they have heart attack. We don't have chest pain. We have pain everywhere else. And we want to make sure that those are recognized and that we seek emergency care. When it comes to women, we're different with follow-up. We tend to say, okay, I'm all fixed. I've got meetings, or I've got family, or I've got things going on, and we miss our follow-ups. Women miss about 2 times more follow-ups than men do. So if you are started on a medication or you have an acute event, I want to make sure that you go to all of your follow-up visits. Your provider and you are a team. Nobody's going to care more about your health than yourself. And so you need to make sure that you're talking well about your concerns, whether that be financial, time management, medication, symptoms. You need to connect with your provider that's taking care of you, whether that be in cardiology or primary care, and make sure that you have a good rapport. If you don't, that's okay. Some people don't mesh. That's okay. Find another provider. Ask for a different cardiologist. You need to be comfortable, in particularly women need to be comfortable talking to their providers. If you're not, find a different provider that you can talk to, that you feel listened to. I want to make sure that your symptoms are being addressed, or your concerns, or if you're not tolerating a medication, make sure that you're having those honest conversations. And the very last thing I will say about women and heart disease is, once again, it's the #1 killer of women in America, and that has to stop. You have to be your most persistent and best advocate. Our healthcare system is overwhelmed on a good day. Our providers sometimes are overwhelmed. Our insurance companies don't do what we want them to do a lot of the time. You have to be an advocate for yourself, because nobody else is going to. If you have a concern that you have heart disease or at risk for heart disease, be an advocate. Talk to your providers. Make sure that you're getting the treatment that you deserve. So that is my talk about vascular heart disease and heart disease in general. There are some recommended research. There's a lot of just generalized research availability for women. I put those here, one of which of course is the Go Red for Women. Cleveland Clinic has a really great website when it comes to women and heart disease. And so I encourage people to go out, do some research, talk to family members, talk to their providers, and make sure that you really take care of your heart, because it really is your home. And if it's failing, nothing else will work. So that's part of our Valley View series today. And I think we're going to open it up for some questions now.
Thank you so much, Katrina, for an excellent session on women and heart health. We have time for just a few questions, so I'm going to ask those now. What is done during a typical screening for heart disease?
That's an excellent question. So it kind of depends on the level of screening we're doing. If we're doing, a preventative screening before we've had an event or without any symptoms, basic screening for heart disease is after the age of 40, and particularly, really truly should have screening before then. But after 40 and particularly, you should have a baseline, what we call EKG, which is a snapshot of the electrical system of your heart. But electrical systems go through muscle and can be affected by plumbing. So it's a very important test, and it really gives us a good idea of how your baseline heart is. Cholesterol panels. Screen your cholesterol panels. We want to know if you have high cholesterol. We want to start treating it before it starts laying down plaque. So EKG, cholesterol panels. Screen for type 2 diabetes. Type 2 diabetes puts you at 5 times higher risk for having a heart attack or stroke. So we want to make sure we don't get there. And so screen for blood sugars with type 2 diabetes. So diabetes screening, cholesterol screening, and then a baseline EKG after the age of 40.
And then if after the age of 40 that's done, how often should it occur after that?
Anytime there's a change in symptom. So if you're just doing baseline screening, if you have a change in symptom or you're on any type of medications, cholesterol panels, lipid panels should be ran every year if you're on a statin or a medication to lower your cholesterol, so that we make sure that you're taking a medication that's actually doing you some good. So every year we want to get a cholesterol panel if you're on medication, or every 5 years. I always tell people every 5 years, repeat a cholesterol panel. And then, of course, anytime you go through menopause, we want to rescreen everything again.
Okay, last question. Speaking of cholesterol, if my cholesterol is high due to genetics, but I'm fairly young and otherwise healthy, should I be worried?
Yes. So if you have a family history of high cholesterol numbers, like I said, those are the gift that just keeps giving, those genes. We want to screen you more frequently. So if you're young, in your 30s or 40s, we want to make sure that your cholesterol panel is screened regularly. And truly, depends on your family history. Some families have high cholesterol but have no history of events. So no one in their family's ever had a heart attack or a stroke, even though they have high cholesterol. Okay, great. That's fantastic. We'll keep an eye on your cholesterol and we'll treat you if we need to. If you have a family history of heart attack or a stroke, and we know that you have high cholesterol, you need to start treating your cholesterol. You need to get that cholesterol, total cholesterol under 200 and your LDL under 100, so that you don't have a heart attack or a stroke later on in life.
Thank you so much, Katrina. Our team would love to hear your feedback on today's presentation. If you have the time to fill out a quick survey, it'll appear right after the webinar has ended. You should receive an email with a recording of the webinar within the next 24 hours. And the next one in our Women's Health series is on Thursday, February 27th at 12 p.m. with Dr. Elizabeth Cruz, who will be discussing menopause. Thank you all again for joining today and have a great afternoon.
Thanks, guys.